Two patients, two lab panels, filling in side by side. Both have a blood sugar that should not be possible. One is 480, the other is 920. And if you only read that one line, you would treat them the same way. Look one line lower. One of them is drowning in acid, the other is not. Same crisis or two completely different ones? By the end of this, you will look at any endocrine panel, a sodium, a potassium, a TSH, a cortisol, and know which hormone is too high or too low, and what the body is doing to try to fix it. This is the endocrine system, all of it. Let's build it from the ground up. Chapter 1, the feedback loop. Here is the one idea that runs this entire system. Every hormone works like a thermostat. There is a set point. When the level drops below it, a gland releases more. When the level rises above it, the gland is told to stop. That is negative feedback, and it is the whole game. Which means, every endocrine disease is just one of two things. A hormone that is too high, or a hormone that is too low. And the feedback loop either failing or trying desperately to fix it. So we will color the whole course by that one idea. Too much hormone, excess, we will draw in warm amber. Too little, deficiency, in a cool, drained blue. Amber is a system running hot, blue is a system running empty. Watch which color a disease is, and you already know half of it. Most hormones do not work alone. They come in a chain. The hypothalamus in the brain signals the pituitary. The pituitary signals a target gland, the thyroid. The adrenal, the gonads. The target gland releases the actual hormone, and that hormone loops back to tell the brain to ease off. 3 levels, 1 loop. When you see a lab, ask which level is broken, because the treatment depends entirely on where in the chain the problem is. That is the frame for the whole course. One hormone, too high or too low, and a feedback loop. Build that picture once, and every chapter after this is just filling in which gland, which hormone, and which direction. When a chapter stops making sense, come back to the thermostat. Our patient is a man in his 40s who has come in twice now for what he keeps calling a flu that will not go away. Tired all the time. Losing weight without trying. And thirsty, endlessly thirsty, drinking and still parched. Nothing about that says flu. Every word of it is a hormone, quietly, already failing. And to see it, you have to start at the gland that conducts all the others. Chapter 2, the pituitary, the conductor. The pituitary sits under the brain, the size of a pea, and it conducts the whole orchestra. It has 2 halves that could not be more different. The front, the anterior pituitary, makes the signaling hormones, TSH, which tells the thyroid to work, ACTH, which tells the adrenal to make cortisol, growth hormone, and the reproductive signals. The back, the posterior pituitary, does not make its own hormones. It stores and releases 2 made in the brain, ADH, which controls water, and oxytocin. Remember that split. The front sends orders, the back handles water. We will come back to the back in Chapter 8. When the conductor fails, it fails in the 2 familiar directions. Too much growth hormone in an adult is acromegaly, the enlarging hands, feet, and facial features. Too much prolactin disrupts periods and causes milk production when there should be none. And a tumor pressing on the gland can knock out several hormones at once, which is why a pituitary problem can look like a thyroid problem and an adrenal problem at the same time. One gland, many downstream effects. Our patient's pituitary is fine. It is sending its signals correctly. The problem is further down the chain, at a target gland that is not answering. But before we get to his, we follow the conductor's first and most tested instrument, the thyroid, and the entire spectrum from too slow to a lethal storm. Chapter 3, the Thyroid Spectrum. The thyroid sets the speed of the entire body, and its diseases live on one continuum, from too slow to too fast. Hypothyroidism, too little, and everything slows down, fatigue, weight gain, cold intolerance, constipation, dry skin, a slow heart rate, depression. Hyperthyroidism, too much, and everything speeds up. Weight loss despite eating, heat intolerance, a racing heart, anxiety, tremor, diarrhea, and sometimes bulging eyes. Same gland, opposite ends. If you know one column, you know the other, because it is simply the reverse. Now the lab that confuses everyone, so slow down here. TSH is the pituitary's signal to the thyroid, and it moves opposite to the thyroid hormone. If the thyroid is underactive, the pituitary shouts louder, so TSH goes up in hypothyroidism. If the thyroid is overactive, the pituitary goes quiet, so TSH goes down in hyperthyroidism. High TSH, low thyroid. Low TSH, high thyroid. It feels backwards because it is a signal, not the hormone itself. Hypothyroidism is treated with levothyroxine, replacement thyroid hormone, and the teaching is heavily tested. Take it on an empty stomach, first thing in the morning, at the same time every day, and take it for life. It is a replacement, not a cure. And do not stop it because you feel better, because feeling better is the drug working, not the disease resolving. Now the two ends of the spectrum that can kill. On the fast end, thyroid storm. Hyperthyroidism tipped into a crisis, often by infection or surgery. A dangerously high fever, a heart rate that can drive the heart into failure, agitation, and delirium. On the slow end, its mirror image, myxedema coma. Severe hypothyroidism crashing into hypothermia, a dangerously slow heart, and a falling level of consciousness. And here is a correction you must lock in. In myxedema coma, you give intravenous corticosteroids first, or at the same time, before or alongside the thyroid hormone, because replacing thyroid hormone too fast in an unrecognized adrenal problem can trigger a crisis. Pause. A patient is started on levothyroxine for hypothyroidism. Which statement tells you the teaching was understood? I will take it with breakfast so it does not upset my stomach. I can stop it once my energy comes back. I will take it on an empty stomach at the same time each morning. Or, I only need it until my TSH is normal. Correct statement is, I will take it on an empty stomach at the same time each morning. Levothyroxine is lifelong replacement, so stopping it when energy returns or when the TSH normalizes is exactly wrong. That normal TSH is the drug working. And taking it with food reduces absorption. Empty stomach, same time, for life. Our patient's thyroid is normal. His weight loss and fatigue are not coming from a slow or fast thyroid. But the thyroid gland sits right next to 4 tiny glands that most people forget entirely. And those glands control a mineral that, out of range, will stop a heart or seize a body. That is Chapter 4. Chapter 4, Parathyroid and Calcium. For tiny parathyroid glands sit behind the thyroid, and they do one job. They guard the calcium level, and they do it with a seesaw. When calcium in the blood drops, the parathyroids release PTH, which pulls calcium out of the bones and back into the blood to bring it up. When calcium is high, they go quiet. So too much PTH drives calcium up, and too little drives it down. And calcium and phosphorus sit on opposite ends of that seesaw. When one goes up, the other goes down. Read calcium by what it does to nerves and muscle. Low calcium makes nerves twitchy and irritable, tingling around the mouth and fingers, muscle cramps, and 2 classic signs. Chvostek, a facial twitch when you tap the cheek, and Trousseau, a hand spasm when you inflate a blood pressure cuff. The extreme is a seizure or a spasm of the airway. High calcium is the opposite. Everything goes sluggish. Muscle weakness, constipation, kidney stones, confusion. The saying is, bones, stones, groans, and psychiatric overtones. This is exactly why the parathyroids matter after a thyroid surgery. The parathyroids are so small and so close to the thyroid that they can be bruised or accidentally removed. So after a thyroidectomy, airway is always first. Watch for swelling and bleeding at the neck. But the second watch is calcium. New tingling around the mouth, a positive Chvostek or Trousseau sign, is hypoglycemia from parathyroid injury, and you keep intravenous calcium gluconate available for exactly that. Our patient's calcium is normal too. We are ruling out the quiet ones and closing in. His symptoms, the weight loss, the thirst, the fatigue, point away from the neck entirely, and toward 2 glands that sit on top of the kidneys and produce the hormone that decides whether the body can handle stress at all. That is Chapter 5. Chapter 5, the adrenal. On top of each kidney sits an adrenal gland, and the outer layer, the cortex, makes 3 things worth knowing. Cortisol, the stress hormone, which raises blood sugar and blood pressure and dampens inflammation. Aldosterone, which holds on to sodium and water and dumps potassium. And a little sex hormone. Cortisol is the one that matters most, because it is what lets the body survive any stress, an infection, an injury, surgery. Too much of it, and too little of it, are 2 completely different diseases. Too much cortisol is Cushing's syndrome, the amber disease. The body looks overfed and overbuilt. A round moon face, a fatty hump between the shoulders, a heavy trunk with thin arms and legs, purple stretch marks, high blood sugar, high blood pressure, thin skin that bruises, and a weakened immune system. Too little cortisol is Addison's disease, the blue one. The body runs empty. Fatigue, weight loss, low blood pressure, low blood sugar, salt craving, and a strange bronzing of the skin. Cushing's is running hot. Addison's is running out. And Addison's has an emergency you cannot miss. Addisonian crisis, when the body faces a stress it has no cortisol to meet. It is a shock picture, severe hypotension, a low sodium, a high potassium, and a low blood sugar all at once. The treatment is immediate intravenous corticosteroids, fluids, and correcting the glucose and electrolytes. And here is the rule that prevents it. Steroids are never stopped abruptly. A patient on long-term steroids has a sleepy adrenal gland, and suddenly removing the drug leaves them with no cortisol at all. They are tapered, slowly, always. Pause. A patient with Addison's disease is admitted with the flu and now has a blood pressure of 82/50, a sodium of 128, a potassium of 5.9, and a glucose of 54. Which does the nurse anticipate giving first? Intravenous corticosteroids, along with fluids. This is an Addisonian crisis, and the missing hormone is cortisol, so replacing it is the priority that reverses the whole picture: the pressure, the sodium, the potassium, and the sugar. Treating each lab separately without giving the steroid is the trap. Fix the hormone and the labs follow. Our patient's adrenals are working. His cortisol is fine. We have now walked the pituitary, the thyroid, the parathyroid, and the adrenal, and every one of them was normal. Which leaves the gland that his thirst and weight loss were screaming about from the very first visit: the pancreas. And this is where his story finally has a name. Chapter 6. The Pancreas. The pancreas runs blood sugar with 2 hormones that oppose each other. When sugar is high, after a meal, the beta cells release insulin, and insulin is the key that lets sugar leave the blood and enter the cells to be used. When sugar is low, the alpha cells release glucagon, which tells the liver to release stored sugar and bring it back up. Insulin lowers, glucagon raises. Every glucose problem in this course is one of those 2, out of balance. Diabetes comes in 2 forms that are mechanically different. Type 1, the body's immune system has destroyed the beta cells, so there is no insulin at all. It usually starts young, the patient is often thin, and they will always need insulin, because there is none to make. Type 2, the cells have become resistant to insulin. The pancreas makes it, sometimes plenty of it, but the body no longer listens. It is tied to obesity and develops over years, and it is managed first with lifestyle and oral drugs, sometimes insulin later. No insulin at all, versus insulin that is not working. Here is the reusable picture that makes insulin make sense. Instead of memorizing 4 drugs, learn 1 graph. Every insulin has an onset, a peak, and a duration. Rapid acting starts in about 15 minutes and peaks within an hour, so it is given with the meal. Short acting, regular, is a little slower. Intermediate, NPH, peaks in the middle of the day. And long acting is nearly flat, no real peak, giving a steady background for about 24 hours. And the single most important thing on this graph is the peak, because the peak is when the patient is most likely to go low. Most common first drug for type 2 is metformin, and it has 2 things you must know. It does not cause hypoglycemia on its own, because it works by reducing the sugar the liver makes rather than forcing insulin out. And it is held around iodinated contrast dye, the kind used in many CT scans, because of a rare but serious risk to the kidneys and acid balance. Assess renal function, hold it per policy around the scan, and resume when cleared. Our patient's labs come back. His blood sugar is over 400, his beta cells are gone, and he is spilling ketones. He is a new type 1 diabetic, and he has been sliding toward a crisis for weeks, which is exactly why he felt like he had a flu that would not lift. And now that crisis is here. Which brings us to the most tested comparison in all of endocrine nursing. Chapter 7. The Glucose Emergencies. For the two famous ones, the emergency with the shortest fuse. Hypoglycemia. Low blood sugar kills faster than high blood sugar, because the brain runs on glucose and starves within minutes. The signs come on fast. Shakiness, sweating, a pounding heart, hunger, confusion, and if it drops far enough, seizures and coma. The rule is the rule of 15. If the patient can swallow 15 grams of fast carbohydrate, wait 15 minutes, recheck. If they cannot swallow safely, it is intravenous dextrose or glucagon. When in doubt between high and low, treat for low, because low is what kills first. Now the comparison. DKA and HHS are both dangerous high sugar emergencies, but they are not the same disease. DKA, diabetic ketoacidosis, is the type 1 crisis. With no insulin at all, the body cannot use sugar, so it burns fat instead, and burning fat produces ketones, which are acids. So DKA is defined by acidosis and ketones. The blood sugar is high, often 300 to 600, but the acid is the emergency. The body tries to blow off the acid with deep, rapid Kussmaul breathing, and the breath smells fruity. HHS, the type 2 crisis, has just enough insulin to prevent ketones, so there is no significant acid, but the sugar climbs astronomically, often over 600, sometimes over 1,000, dragging out enormous amounts of water and leaving the patient profoundly dehydrated and altered. DKA, acid and ketones. HHS, sky-high sugar and dehydration. The management shares a spine and the order matters. Fluids first, because both patients are severely dehydrated, and fluid alone starts bringing the sugar down. Then insulin, an intravenous drip, to shut off the fat burning and let sugar back into the cells. And here is the potassium trap that is tested constantly. Insulin drives potassium out of the blood and into the cells. So even when the potassium looks normal or high at the start, it will fall, sometimes dangerously, once insulin starts. Check the potassium before you start insulin, and replace it as ordered, and do not lower the glucose too quickly, in either one, because dropping it too fast pulls water into the brain and causes cerebral edema. Pause. A patient in DKA has an initial potassium of 3.3. The provider orders an insulin drip. What does the nurse do? You hold the insulin and notify the provider because the potassium is already low and insulin will drive it lower, into a dangerous range that can stop the heart. Potassium is replaced first, or alongside, before, or as the insulin begins. Starting insulin on a potassium of 3.3 without addressing it is the trap. Fluids and potassium come before, or with, the insulin, not after. Our patient gets fluids, careful insulin, and potassium, and over hours the acid clears and he stabilizes. He is taught to live as a type 1 diabetic. And 2 weeks later, he is back. Not with high sugar this time. He took his mealtime insulin, then got distracted and skipped lunch, and his rapid insulin peaked, on an empty stomach, with nothing to cover. That is the other side of the same coin, and it is why the peak on that graph mattered so much. Chapter 8. Water balance. Back to the posterior pituitary, and the water hormone, ADH. ADH tells the kidneys to hold on to water. So the two diseases here are simply too much ADH or too little, and they are perfect mirror images. SIADH, the syndrome of too much ADH, the body retains water. That water dilutes the blood, so the sodium falls, the blood is dilute, and the urine is concentrated. The patient is water overloaded and low on sodium. Diabetes insipidus, DI, is the opposite. Too little ADH, so the kidneys cannot hold water. The patient pours out huge volumes of dilute urine, becomes dehydrated, and the sodium rises. One holds too much water, one loses too much. Everything else follows from that. So the treatments mirror too. SIADH, too much water, restrict fluids. And the sodium is corrected slowly, never quickly, because raising sodium too fast injures the brain. DI, too little water, replace the fluid and give desmopressin, which is synthetic ADH, to let the kidneys hold water again. And do not confuse this diabetes with the sugar one. Diabetes insipidus has nothing to do with blood glucose. The word diabetes just means a large flow of urine. Pause and select all that apply. Which findings fit SIADH, the syndrome of too much ADH? Low serum sodium, large volumes of dilute urine, concentrated urine, water retention and weight gain, high serum sodium. SIADH is low serum sodium, concentrated urine, and water retention with weight gain. Large volumes of dilute urine and a high sodium belong to the opposite disease, diabetes insipidus. The trick for any question like this, ask first, is ADH too high or too low? Too high holds water, dilutes the blood, drops the sodium. Then everything else sorts itself. Our patient's water balance is fine. His crisis was sugar, not water. But notice how many of these diseases came down to a single hormone. One direction and a handful of drugs pointed at it, which means it is time to put every drug in this course onto one map. Chapter 9. The Drug Map. Bring back the frame. Every endocrine drug is either replacing a hormone that is too low or blocking one that is too high. Replacing the low ones. Levothyroxine for the thyroid, empty stomach, lifelong. Corticosteroids for the adrenal, never stopped abruptly, tapered. Insulin for the pancreas, dosed by the onset peak duration graph. Desmopressin for diabetes insipidus, replacing ADH, and blocking or lowering the high ones. Antithyroid drugs for hyperthyroidism. And metformin, which lowers the liver's sugar output in type 2. If you know whether a hormone is too high or too low, the drug picks itself. And the traps that live in these drugs, gathered in one place. Levothyroxine, empty stomach, same time, for life. Do not stop when you feel better. Steroids, never stop abruptly, taper, and expect high sugar and a lowered immune response. Insulin, know your peak, that is when they go low, and insulin drops potassium. Metformin, hold around contrast dye. And desmopressin, watch for the opposite problem, holding too much water and dropping the sodium. Same hormone logic, every time. Pause and put these in order. A patient with new type 1 diabetes is admitted in DKA. Put the first interventions in the correct sequence. Establish airway and breathing and start large bore intravenous access. Begin isotonic fluids first, for the dehydration. Check the potassium and replace it as needed. Start the insulin drip. And monitor glucose, potassium, and the acid closely, adding dextrose to the fluids as the glucose falls so it does not drop too fast. Fluids and potassium before insulin. That order is the whole answer. Chapter 10. Put it together. Every endocrine decision fits the same 6 questions the next generation NCLEX is built on. What is happening? Recognize the cues. Why is a hormone too high or too low? Which finding matters most? And in endocrine, that is often the potassium, the sodium, or the glucose. What could I do? What do I do first? And did it work? Did the hormone, and the labs that follow it, correct? Read the direction first, and the rest becomes arithmetic. One last patient, unfamiliar on purpose. A woman with a long history of taking prednisone for an autoimmune disease ran out of her pills 3 days ago and did not refill them. She now has severe weakness, a blood pressure of 80/50, nausea, and she looks like she is going into shock. Her sodium is low and her potassium is high. Take a moment before I say anything else. Walk it. What is happening? A shock picture with a low sodium and a high potassium. Why? She abruptly stopped long-term steroids, so her sleepy adrenal glands have no cortisol and she has crashed into an adrenal crisis. Which matters most, the hypotension and the hormone driving it? What first? Immediate intravenous corticosteroids and fluids, which reverse the whole picture at once. And the lesson tucked inside it, the one that would have prevented all of this: steroids are never stopped abruptly. Everything you needed was in chapters 1 and 5. If you keep 5 things from this course, keep these. 1. Every endocrine disease is one hormone too high or too low, amber or blue. 2. TSH moves opposite the thyroid. High TSH means low thyroid. 3. Hypoglycemia kills faster than hyperglycemia. When in doubt, treat the low. 4. In DKA, fluids and potassium come before insulin, because insulin drops potassium. 5. Never stop steroids abruptly, and know that a stressed patient on steroids may need more, not less. And back to where we started. 2 patients, both with a blood sugar that should not be possible. One at 480 with a low pH and ketones. One at 920 with a normal pH and no ketones. You had no way to tell them apart at the start. Name them now, and name the one thing their treatment shares. First, with the low pH and the ketones, is DKA, the type 1 crisis of acid. The second, with the sky-high sugar and no acid, is HHS, the type 2 crisis of dehydration. And the one thing their treatment shares: fluids first, then insulin, with potassium watched like a hawk. Same one line of lab, 2 completely different patients. Completely different nurse. That is the endocrine system. Not a pile of glands and hormones, but one idea repeated. A hormone too high or too low, and a loop trying to fix it. There are over 1,000 free study guides at clinicaljudgern.com. No paywall, no catch. If this helped, like it, share it with someone in your cohort, and tell me which system to build next. Educational content only, not medical advice. Go be the nurse who reads the direction first.